Nearly a quarter of human cancers arise in the gastrointestinal tract. Almost all of them are accessible by endoscopy and have identifiable and often treatable precursors. For example, Barrett's esophagus and colonic adenomas are well-known precursors of adenocarcinoma at their respective sites. Both lesions are widely studied with a focus on improvement in their detection, natural history, and impact of endoscopic intervention. However, according to Western literature, the stomach seems to be the outlier in this discussion. This is surprising because the number of gastric cancer cases is expected to increase in Europe in the next 2 decades. In the stomach, gland loss and intestinal metaplasia have long been recognized to be associated with an increased risk of gastric cancer. Increasing research on gastric atrophy has led to recent guidelines recommending that individuals with extensive severe atrophy and metaplasia should be identified and kept under surveillance. These recommendations were based on studies that used random gastric biopsies to assess gastric atrophy and metaplasia, which can be multifocal. For this purpose, biopsies should be obtained from both the antrum and corpus. Diagnostic accuracy increases with the number of biopsies, but for practical reasons, the numbers are usually limited to at least 2 from the antrum and 2 from the corpus. Efforts have been made to translate the resulting histological information into staging rules using either atrophy or intestinal metaplasia, which is a more advanced precancerous lesion and is associated with a higher observer reproducibility. Patients with moderate to severe lesions at both locations have a significant risk for progression to dysplastic or neoplastic changes during follow-up. Although random biopsy sampling from the antrum and corpus, subsequent staging, and the recommendation for surveillance of subgroups provide the means to identify and manage patients at risk for gastric cancer, it should be kept in mind that random biopsy sampling may miss relevant lesions. These changes are multifocal, and without endoscopic targeting, focal changes may easily be under or overdiagnosed. Furthermore, the sampling of biopsies poses a burden to the routine endoscopy setting, both in terms of workload and cost. Thus, the accuracy and impact of image-enhanced endoscopy for assessment of pre-malignant gastric changes has become relevant. This is fully in line with the developments in other areas such as Barrett's esophagus and colorectal polyps. Dinis-Ribeiro, in his paper entitled Identification of Gastric Atrophic Changes from Histopathology to Endoscopy, suggests that there is a need to reset the clinical and research agendas, with research focused on placing endoscopy as the gold standard for the pre-malignant stomach. He has the following recommendations to make. Larger observational studies should focus on strengthening the evidence for use of the new image-enhanced endoscopy techniques for the assessment of intestinal changes in the gastric mucosa, focusing on intra- and inter-observer consistency and accuracy of severity grading. Second, patients can be enrolled in studies with various designs. Randomization to compare different technologies, different modalities of endoscopic assessment with histology assessment as the outcome, or randomization to endoscopy versus histology. In this case, other risk factors for individuals to harbor precancerous conditions should be recognized and assessed, as predictive values are affected by these. Third, the evidence on the natural history of gastric precancerous lesions must be revisited in order to provide an accurate incidence rate for gastric cancer. This will help to ensure that surveillance is targeted, or where surveillance is deemed unnecessary in certain phenotypes, that this is safe for the patient. It will also help to schedule surveillance and further measures for those with pre-malignant stomachs. Endoscopic technologies should be considered in a continuum. The final application of an endoscopic method to estimate an individual's risk of cancer will also depend on the epidemiological context, such as the prevalence of Helicobacter pylori infection.